I'm Dave Casper. Welcome to another interview here at Inclusive Magazine. Our guest today is Dr. Paresh Patel, a general dentist in private practice in North Carolina. Paresh, thanks for being here today.
Absolutely. Thanks for having me.
You're welcome. Now, you went to dental school at UNC. You graduated in 1996?
Correct. I went to undergrad there. I grew up in North Carolina in Greensboro, and then I went to Chapel Hill for undergrad from '88 to '92, and then went straight into dental school from '92 to '96.
Great, great. So this is an implant-focused magazine, so I have to ask, what was the implant curriculum like at UNC in the mid-90s?
Sure. So the implant curriculum for us as undergrads was, this is an implant, stay away from it. So that's about as close as we got to an implant. Even in the oral surgery department, you know, we could maybe, if we were absolutely lucky and we're in the right place at the right time, to watch an implant being placed, and that's about as close as we got to it. There was no courses that you could sort of sign up for as an elective or something like that.
So no graduation requirement to restore a given number of cases?
No, even in the removable section we weren't exposed to a locator. So these things were all reserved for GPRs or for advanced training if you decided to stay at Chapel Hill.
Wow, wow. So you're a fairly well-known and extremely well-published implantologist. So how did you make the leap from no education in your dental program to getting involved in implants?
Well, when I graduated, I moved to Hickory, North Carolina, and I have a practice in Lenore, North Carolina. So it's a rural, blue-collar sort of environment. Lots of extractions, as you can imagine, as the sort of the course of treatment for a lot of people, a lot of dentures, a lot of partials. So from '96 to about 2006, I just saw people suffer, and I was underneath the impression that if I border molded and took the best impression possible and did everything exactly right, made sure I had bilateral occlusion, the denture would fit and my patients would be happy. But you know, 10 years of getting worn down by patients that saying, Dr. Patel, this denture hurts, this denture doesn't fit, it makes me gag. I finally felt like I needed to do something, so I signed up for a denture stabilization course, a mini implant course, and that was my first sort of step into it in 2008. 2008,
so you went a good decade before getting involved?
Absolutely, yeah. Somewhere in there, you know, maybe in about 2005, 2006, local periodontist in my area sent me a patient that he had placed 4 traditional sized implants and placed locators on top of them. And I had zero training on how to restore this, so it was a huge learning curve and was almost like I'd stepped into a dark room trying to figure out how to do an overdenture for the first time.
So the implants were placed, the patient was referred to you, hey, restore this.
Yes. So the patient walked in, I read all the clinical notes, and I had no idea there were Nobel replace implants, and you know, I picked up the phone and called Zest, the locator company. And I said, I need to read you this verbatim because I'm not certain what I need to order. And I said, it says the implants placed were, you know, 4.3x13. And I could just hear the lady laughing on the other side. She's like, it's not an X, it's by. And I said, well, I need to make sure I read this to you absolutely correctly to make sure I order what I need.
Here's the lot number.
Yes, yeah. And she thought I was absolutely nuts.
But did you get what you needed?
We got what we needed. I called the periodontist. He was gracious enough to walk me through it. Then when the patient came back in, I didn't have the hex driver. And so I called him, sent one of my assistants to go get the hex driver, took the healing caps off, and then I went to screw the locators in and then realized I didn't have a locator tool. So I had to call him back and send the assistant back there. So it was not a smooth transition for my first sort of overdenture or experience with implants, and that probably explains maybe the 2 or 3 year old lull there where I was like, this is not really for me, it's too complicated.
Maybe they were right at UNC, just step back.
They might have been, yeah. You know.
But then you took a course, a denture stabilization course, focused on small diameter implants. Tell us about that.
Right, so the real excuse was probably to go to New York. So I was like, all right, I'm going to be in New York. I might as well get some experience out of this. So I signed up for a mini implant course. And it was purely for overdenture stabilization, which is really what I wanted to learn. And you know, the course was presented very nicely. I bought all the materials I needed and came home and I lined up, I think, 6 cases to start with. I had 3 one day and 3 the next day.
Wow.
So I jumped in the deep end of the pool, and that probably is not the best way to start this because I realized I needed probably a little bit more hand-holding for my first few cases than just to say, drill a hole, place implanted hole. And that is the simplistic fashion of it, but I didn't follow through with what I think is the most important part, which is to take some study models and do some bone sounding to realize, is this a wide enough ridge? Is this all tissue? Is there bone here? Which way does the bone slope? And do a little bit of homework on anatomy and things like that.
So, but you had 5 or 6 patients lined up over those first 2 days. How did you choose those patients? Were these dentures that you had already done and they were unhappy with them, or were they new patients?
Sure. So the way I did it was I just went into hygiene, and everybody who had a partial or a full denture, or maybe one arch had a denture and had some opposing teeth, I said, would you consider letting me place some implants on you, see if we can make you a happier person. If you're happy, please pay me what you think is a fair fee. So that's how I really started my journey. Was I wanted the experience, I wanted the patients to have a better quality of life, and it wasn't necessarily the money that was a motivating factor. Of course, the money is nice, but I wanted to develop enough skill to get these implants in and then be able to charge what I felt was appropriate to get them done for the rest of the patients.
So the question on everybody's mind right now is, did any of those patients pay you? Were they happy?
Yes. The first couple, it took a while to make them happy because the implants weren't placed in the ideal positions, okay? So you learn as you make a few mistakes, and I think that's the best way to approach implant dentistry, is to try not to make those mistakes initially, but you do have to physically get out there and do it yourself. You can't just sit in the back of the room and go to 5 or 6 different implant courses and not take the plunge.
Yeah, yeah. So after those first 6 cases, was there a period where you didn't do any more cases so you could apply lessons learned, or did you stay in the deep end of the pool, so to speak?
No, our progression was we stayed in the deep end of the pool. It just ultimately snowballed that one patient will tell another, will tell another, and it was almost like, well, Dr. Patel is the the overdenture guy, and I was in the right area for it too, being in a blue collar area. So really, my first 3 or 4 years was mostly overdentures, not really single unit crowns.
Right, right. But you're certainly a big advocate for small diameter implants, and also the co-founder of the American Academy of Small Diameter
Absolutely.
Implants. Tell us about that organization.
Oh, yeah. It's really out there to not be manufacturer supported. We're out there to have speakers that come from just about every manufacturer. So we'd like for doctors that maybe use 3M SB's MDI implant, or use Park Dental implant, or use an Intralock implant to come in, or even the Gladwell Mini for this matter, to come in and talk about their experiences and how they've solved problems that if I only went to one manufacturer's courses, I'd probably get the same information over and over again. So really a melting point for lots of information to come together in one spot.
Yeah, good. But you've since transitioned, or at least started to include, let's say, standard diameter implants into your armamentarium. Tell us about that transition. Was there a specific case that mini implants didn't work? Was it another course? How did you decide to get into a new pool?
Sure. After about 2 or 3 years of just doing nothing but minis, I had a patient that had an extremely wide area of bone. It was in the posterior maxilla, and it was just not a great spot. I initially tried to place some minis there, and it would just be that the implant would engage but wouldn't give me that stability that I wanted. And I said, if I had a different tool in my toolbox, maybe a larger implant, would that be a better spot for it? And certainly it would have been a better spot for it, and probably would have given me the success I wanted to from the initial beginning. So I started flipping through a few magazines, and I stumbled across the AAID Maxi course, which is in Georgia, so not that far away from North Carolina. So I signed up for that year-long continuum, and that really gave me a good basis for applying how to incorporate standard diameter implants into my practice. So I was absolutely thrilled with the education there, and exposed me to all the things I didn't know to ask for. So it was almost one of those that if you don't know concepts.
Right, right. So then you finished the course. It was a year long, you said?
Correct.
How long did you wait before you treated that first patient with a standard diameter implant?
Oh, I think as soon as I went through the first couple of meetings, I went ahead and bought the standard body implants that meeting, and went back and applied it. And it really was as simple as adding 1 or 2 more drills to the protocol. You make your pilot hole, then you expand expand it, and then place the implant.
You mentioned earlier single tooth applications, for example. So that's the type of implant case we see the most frequently here at Gladwell Laboratories, just the single unit, most of the time a posterior single unit dental implant case. Talk to us about how you treatment plan those cases, implant selection, screw retained versus cement retained restorations. What's your philosophy in that area?
Sure. In our office, I just came up with a real simple checklist, and what we do is we take the study model and we mount that, and then we have a checklist that says mesial distal space, buccal lingual space. So we'll bone sound or we'll get a cone beam, so we'll know exactly how much space there is between the adjacent teeth. Mesial distally, we'll know how much width we have of bone buccal lingually. and I also incorporated in there soft tissue, like how thick is the soft tissue. Sometimes I see better success when we have more soft tissue than not enough soft tissue. So the diameter of implant is important, but I'd rather have enough volume of bone and then on top of that enough volume of tissue. And certainly I like to have some keratinized tissue as well. So if we don't have keratinized tissue, it makes for a good conversation with the patient that yes, we could have good success. However, when I pull your lip, we see that there's nothing attached here. That will decrease the long-term success. So it's starting to make me, or forcing me to become a little bit more proactive with the patient to tell them, do we need a connective tissue graft ahead of time? I'm not advocating that every time I do a connective tissue graft, but it's certainly nice to tell the patient a lot of these things before time. Screw retained or cement retained, you know, most of my upbringing has been cement retained. I don't have a preference one way or another. Really, if I can get a screw retained crown and I don't have the screw access hole coming up right there in the central fossa, then I'm more likely to do that. But for cost reasons, a lot of times a stock abutment, you know, makes sense. But even now, I'm starting to not use less and less stock abutments because to try to force that margin of the crown well up underneath the gingiva and get that cement out has been a nightmare on certain cases. And I wished in my evolution I had been more accepting of a custom abutment. And now 99% of the time we're either doing a custom abutment and a cement retained crown or a custom abutment and a screw retained crown.
Good. Let's talk a little bit about immediate provisionalization, immediate temporization. Is this something that you do in some of these cases? Is it location specific in the mouth, or tell us a little bit about your philosophy?
Well, when I first started, there was no temporization because I was scared. But now
Healing abutment.
But now I think, you know, I've gotten over that fear. And I would say that trying to preserve that soft tissue volume is actually more important than I had initially realized. If you don't preserve that with a contoured healing cap or a custom healing cap, or try to load it, when I say load it, not in function, but just as in an immediate sort of temporization of the tooth, we're not getting that soft tissue profile like we would want to. Right. So my philosophy has turned even in the posterior. If we can put in a custom contoured healing cap, we're going to come out with a better solution for the patient because now we don't get that food that traps underneath maybe the mesial of the number 19 or the number 30 where we have a real bulbous crown that we're trying to come by and get to the right contours by not having that soft tissue from the get-go. Right. So if I can have the ability to put a tall healing cap in that we've either contoured with composite, or if we've done an ITRS solution, we can go ahead and have that custom healing cap from day one, that if we don't have the stability to put a temporary on it, we can at least preserve that soft tissue volume.
And you have that for down the road anyway, good evolution for
absolutely,
the patient.
Absolutely. Yeah, so you've got all the parts and pieces that you need.
Earlier you mentioned cone beam technology, and in several of the articles that we've published in this magazine that you've submitted, there's been some great work in the guided surgery area.
Sure.
So talk to us a little bit about your use of this technology. When do you decide to go guided? When is it not necessary, or why wouldn't it be necessary? Give us some
sure.
Give us some insight there.
You know, I have two offices. In one office we have a CBCT. We've got an iCAD at that office. The other office we just have a digital pan. My iCAD is now 5 years old, so I couldn't believe it, but I just made the last payment, so now I know that it's done. So it's been 5 years.
Now it's going to break.
Oh yeah, I hope not. Let's hope not. But I jumped into the cone beam because I got tired of opening up a flap and then realizing that the volume of bone I thought I had was not there. And I said, there's got to be a better way. And I thought to myself, if I invest in this technology, will it pay off? And for my office, it has 100% paid off. The volume of cases we do has gone up, and the volume of cases we know that we're going to need to refer out to our specialist, the periodontist or the oral surgeon, for some sort of grafting has gone up as well, because now we don't have to waste our time, the patient's time, and also healing process for opening up a flap and saying this is not going to be possible without the help of someone more qualified than myself. So that in itself I think is a good reason to consider the technology. It also allows me to do what you guys always preach, which is prosthetically driven sort of treatment planning, that I know the end result before I even touch the patient with a scalpel. So I like that. I can pick out diameter sizes before. I can make sure I have in stock what I think I need for lengths, and if I don't, I can go back and review the treatment plan again. There's great companies out there, such as 3DDX, that will convert scans for you. If you say, I'd like some help treatment planning, they can put it into their co-diagnostic software and then convert it over into something that almost looks like a virtual model that's very understandable by the patient as well. So once the patient can see the 3D technology, that usually helps move the case forward as well.
So that helps during the consult. They can
absolutely. So every time I do
explaining.
Absolutely. So when I'm doing a consult, I always have the 3D images up in place. Now, if I just had the raw CT images up, it's hard for the dentist to understand it. I can't imagine for the patient to understand that they would even know what they're looking at. But you get it converted into a model format. It's very easy for them to see, this is my jaw, this is the bone I have left, this is why the doctor's proposing this sort of treatment plan, or this is why he's proposing no treatment plan unless I get grafting or ridge expansion.
Right, right. And so for the office, you mentioned you only have a digital pan. Do you not do implants in that office, or?
No, we do. And there's a great website called conebeam.com for those doctors that don't have a 3D CBCT in their office, that you can go and you can find offices that do have cone beams that will let you send your patient there, or a scanning center. What I have found is that if you'll make relationships with your oral surgeon, orthodontist, endodontist, or prosthodontist in your area, you might find that one of those 4 guys has a cone beam in their office. And we've made an arrangement where we just pay $100 a scan, and they take the scan for us. And I was like, for $100, I just absorb that cost to get the patient to move forward. Yep.
Great.
Yeah.
And for those cases that the cone beam scan leads to a surgical guide, do you also absorb that cost, or is there an extra fee for the patient?
What I tell the patients after I look at the initial cone beam scan is, if I feel like this is going to be a good case that can be done, I'll ask the patient to pay $1,000, and I'll apply that $1,000 towards whatever treatment that they finally accept. But that's going to cover the conversion, the treatment planning, and the guide, all in that $1,000. Right. So I haven't lost any real effort and time. The patient has something they can walk away with, which is the treatment plan is theirs to keep. Even if they don't decide to do it, they can take it to whoever they want to take it to. Yep.
Great,
yep.
Great. Staying on the digital conversation for a while, last night at dinner we were talking about digital impression technology. You mentioned you have an iTero unit. When did you incorporate this, and what impact has that had on your practice?
I bought my iTero 7 years ago at the AACD conference, and it was one of those impulse buys. I think I'd never seen a digital scanner before.
As manufacturers, we love it.
Yeah, and I had sucker written on my forehead that day, I guess. But really, that was one of the best purchases I ever made, because I could not live without my iTero. So 7 years later, my iTero is still going strong. It just needed the batteries replaced in it. But nonetheless, if I had a few things I could not live without, it would be my cone beam and my iTero. For single units, full arch, whatever it is, I love it. I even like putting the scanning flags on it to send a digital impression to Gladwell to make the implant, abutment, and crown off of that. So I think it's something that every dentist should at least look into. The iTero for me has worked out fantastic.
Better result digitally.
Absolutely. No, hands down, no way that we could do the same thing with a traditional impression versus what we could do with an iTero.
Great, great. Earlier you mentioned, we were talking about treatment plan acceptance, and I think a lot of our viewers would appreciate understanding your point of view on increasing case acceptance, getting more patients to say yes. You, as a general dentist in a blue-collar area, as you mentioned, you do a ton of implants. So what advice would you have for some of the dentists out there to get going more?
Absolutely. So really, I think you have to be not afraid to ask. I'm now guilty of being a hole filler. So my staff, my hygienist have said, "Doctor, you're just not diagnosing decay like you used to," and I am guilty of that, because I'm so excited. I see the empty space, my eyes immediately go to this and say, "We could put a piece of titanium here," and I think that has become that way because I'm not afraid, and I walk into the room with confidence, telling the patient, "Miss Smith, you need an implant here. We can give it to you. We can perform the entire procedure in one office at a very reasonable cost now, because we're not asking you to go see 2 or 3 different doctors to get it done." I had this conversation with Dr. Nazarian a few weeks ago that said, "Dr. Nazarian, you're doing all these wonderful, huge full arch cases, even full over full. Where are you getting these people from? How are they accepting it, and where are they coming up with the money?"
You didn't think you had those same patients in your
absolutely.
practice?
So in my mind, I said, everyone has X dollars enough for an overdenture. And he said, "Well, you're just not asking for it, Paresh." And I said, I am. He said, "Well, you're not asking for it, and asking with confidence that you can deliver what you're saying you're going to deliver." So I really took that to heart, and I said, introspectively, am I doing that? And I came across with that I was. So I made it a concrete goal for the next 3 months that everybody who came in for an overdenture consult, I would propose that good, better, best solution to them. Mm-hmm. And inevitably, we started seeing these full arch cases saying, "Yes, doctor, I think I will do that Bruxer full arch bridge on traditional implants like you were talking about."
So the patients were there.
The patients were there. They were just steered because the way that I wanted to do it, not necessarily that I put the 3 options on the table and said, "Solution A is the best, this one's not as good, and this one is just the bare minimum dentistry that you need." So I think once they know their choices, they go home, they talk to their spouse, and inevitably they come back with Care Credit or Springstone. And we're starting to see that they'll accept the entire amount, and then they'll figure out a way to get it done.
Great,
Yep.
great. Good advice. We really appreciate you being here.
Oh, thank you very
Thanks,
much, Dave.
Paresh.
Okay.
Thanks.